volume of numbers of fractures, their severity score increases. They have other injuries that need to be taken care of, and other considerations and body systems that need to sort of have a team approach at places that are bigger volume that can handle them. So other complex fractures that they like to do, that become that have a high association of problems associated with them, such as increased rate of infection, plateau fractures where you have the joint surfaces involved at the proximal end of the tibia, at the knee. Pilon fractures, the same problem at the ankle. Calcaneus fractures. All those can be difficult fractures, sort of tedious fractures to deal with, just putting back the little pieces, and and the pelvis fractures that are 18 hours, and you flip them from one side to loosen everything up, flip them to the back to fix the back, flip them back and fix the front. So that's more of what a traumatology orthopedic surgeon can do.
Other questions? Scott's used to, yeah, Eric?
Are you in surgery on a daily basis, or is your week mostly dealing one-on-one with patients and x-rays, and you may do a couple surgeries a week?
Right. Usually our practice is set up where we are in surgery 2 days a week. We have one day that for us is an outpatient surgery center, sort of the quick outpatient stuff such as smaller fractures, scopes of shoulders or knees, even ACL reconstructions that you typically send home. You can do at your surgery center. There's a little bit quicker turnover time, a little bit more efficiency. The bigger cases are done on a different day, so which is the ones that have to stay over, like your total joint replacements, hips and knees, shoulders. Those that you anticipate bigger blood loss or needing a little bit more critical care or following over a couple of days. So in general, our office, we have a day at the surgery center and a day at the hospital. The way we coordinate who's taking call, the day we're at the hospital for doing those bigger surgeries, that person at the hospital will cover the ER for random fractures that come in that need attention that day. So the rest of my week, I have 2 full days of clinic and 1 half day of clinic, where I'm seeing probably on a real full day 34 patients in a full day. Some of my partners do a better job at running through patients and see 40 to 50 patients a day for a full day, and that's just their individual style and efficiency. I'll sit there and gab a little bit too long, I think. So,
okay.
I've heard that orthopedic surgery is not a common practice for women to go into because you have to have a lot of upper body strength. Is that true?
It is true to an extent. I mean, there are becoming more and more orthopedic surgeons that are women. It used to be, every subspecialty, like I said, hand surgeons or hand weenies. Every surgical specialty sort of has its own stereotype. Orthopedics, the dumb or smart jocks, if you will. The ENTs tend to be more pretty boys, or metro, or you get and follow me. So in general, yes, orthopedics surgeons often, a large number of them are collegiate or professional athletes and are typically strong. There is a bit of wrestling with the patient's leg to do the case, or manipulation involved. So there is some of that, but certainly the numbers of females in orthopedics are increasing. I tend to see a trend toward the subspecialties like foot and ankle or hand, where there's less of the sort of the bravado and the doing the heavy manipulation stuff. But that being said, you know, there is a famous orthopedic surgeon who is a little person, a midget. And so he has to stand on however many stools because the beds don't go that low. And so and you know, as far as a mechanical advantage, you probably are stronger than he is to be able to work a hip or knee back in, hip dislocation back into place. So, but he's able to do it. There's plenty of women that are doing it, and you know, it's not impossible. But in general, orthopedics has been sort of a males-dominated boys' club.
Question.
Yes.
How would you describe the stress level now?
Currently, it's fairly low. The other talk that I gave for sort of the timeline, my timeline of orthopedics from high school to now, residency and med school, it was a high stress level. But you make of it what you will. I mean, there's certainly doctors who, you know, stress about every little thing and being sued by every last patient and what can I do to avoid that. And in general, most surgeons are sort of type A and very anal and, you know, have to have everything in line. But I'm not your typical surgeon, I think. I'm sort of way more type B as far as, you know, compared to other surgeons. So I'm not going to let things stress me out too much either.
Scott is used to me doing a duo with him, so
go for it, dance.
But we interact a little bit to try to prime you guys. And I just want to tell a story. My son-in-law, Lisa's husband, was snowboarding in Colorado here just 3 weeks ago, and he took a bad fall and he had a compression fracture. So what is a compression? Let's see if anybody in the class here knows. What would you say a compression fracture is? You know what a compression fracture is, don't you?
I mean, typical compression.
What, like of the
spine?
Of the spine.
Yeah.
He had a compression. He has a compression fracture of his T1.
Huh.
So
how far was he going?
25%. So he's got 25% compression.
Okay.
So all this means stuff to him, but so I'm wondering what I asked him. He said compression fracture. I said, what's the difference between a fracture and a compression fracture?
Right.
So you know the difference between a compound and a simple fracture. My teaching is coming up.
Go for it.
Okay. So Eric, you know the difference. We're going to cover this in class. So what's the difference between a compound and a simple fracture?
I may be wrong, but I thought a compound fracture is when the bone's exposed.
Okay, you got the expert here.
And then a simple fracture is a simple fracture. You fall and you fracture your arm, but it's not jarred out when you see a piece of bone sticking out.
So
Right.
he gets
It's less of an emergency
Get some
situation.
credit there.
You get credit there. All right. What's the green stick
That's when
fracture?
it bends. It doesn't actually fracture.
So there's
Correct.
it's just bending.
It's very much like a green stick when you try to break it over your knee and it breaks and you lose some of the structural integrity there, but again, some portion of it is still together, so it wobbles, or you could swing it around and it's still one piece, but
Maybe
it's got a
splintering.
significant weakening. It's not necessarily splintering, and often when I see kids are the ones that get green stick fractures. Their bones are a little bit more softer or pliable. Often it's called a buckle fracture, and what I liken that to is if you have a cylinder like a Coke can and you don't have any dents in it, you can generally stand on that Coke can, but once somebody knocks in the sides, it makes it significantly weaker. So a lot of times when kids fall on their arm, it bends, or there's a dent or a buckle in the cortices, which makes it there structurally weaker, but it's not two pieces. That also is considered a green stick, where it's not two complete pieces, but just one piece. And usually we don't, medi speak or ortho lingo, we don't refer to it as, what'd you call it?
A green stick?
No.
Splintering?
Open.
The
Compound, right. That's sort of layman's term. We say open or closed,
Okay.
simple or comminuted. Comminuted means, lots of pieces. And then for kids, it can be buckle, green stick.
Okay. So what about the compression fracture? What's going on there?
So generally they call compression fractures of the spine, or where the spine is a cylinder and it sort of wedges down but doesn't explode. The ones where you have a wedge and a burst pattern, they're called burst fractures, and usually that involves some of those pieces, and usually younger people, they get burst fractures instead of just compression fractures. And some part of that pushes out and other parts push back into the canal. They used to consider operative fractures needing stabilization or burst fractures with greater than 50% loss of your height, or greater than 50% canal compromise, with enough of those fragments are back there pushing on the spinal cord. But in general, they look at neurologic status. So if there's some incomplete neurologic loss, with enough of those pieces pushing on the back of the spine, or there's enough instability as determined by the numbers of columns that are still intact, to fix it or not.
Right. And let me just follow up on my story. I'm just trying to
Sounds like
get a free consultation.
Sounds like his is non-operative.
Right. So let me
take it easy.
Let's go on with it. Let me go on with this story a little bit. But he knows my daughter, and I don't think he's met my son-in-law. But they live in San Diego, and so it's long distance with phone calls and talking about all this stuff. But he did this in Colorado, Denver, snowboarding, and then he went back to San Diego. And just 2 days ago, he called me with all this from having gone to see a spine specialist.
Right.
Right. And so the spine specialist did the x-ray, looked at the CTs and all that, and he actually took the x-rays and he took a ruler and he did he actually measured, took a grease pencil and marked and said you got 25% loss of something or other.
Okay.
If it was 50% or better, he would say we needed to do surgery.
Correct.
So he's right now saying you don't need to do surgery. They have him in a full torso brace. He's got to be in that for 3 months. And so they've got, he's got that situation going on right now. But this guy described to him, if he were to have surgery, the surgery would involve them going in and putting him on his side, opening up his side, collapsing his lung, going in and putting a plate in on one side, flipping him over, going into the back and putting another plate back there, and then reinflate the lung or put a chest tube in him, put him in ICU for 2 or 3 days, make sure that everything got back to normal. This is snowboarding, guys. He just, you're young, this could happen to you. So this is just sharing this with you because it's kind of ties in on what we're doing. So does that sound like that he could, if he should, now with his back brace, if he takes the back brace off and he says, then the compression fracture could go from 25% to over 50%, and he would be under the knife and have to go through all that rigmarole for his getting repaired.
It can, it's unlikely.
Yeah, okay. But he should keep that back brace on him?
That's his doctor's orders.
Yeah.
That's the person who actually saw the film. A film,
right.
Picture's worth 1,000 words. Yeah. And so far, you're still working about 250 there. So yeah, I mean, it can. And usually, what we do, when I was in residency, typically we don't deal with any spine fractures. Those go to a spine surgeon.